Hello, my name is Scott Paxton. I'm one of the shoulder and elbow surgeons here at University Orthopedics, coming to you as part of the community lecture series. I'm going to be talking a bit about shoulder pain, shoulder arthritis, and shoulder replacements. And that's what we're going to talk about for the next 15, 20, 25 minutes. Like I said, I'm one of the shoulder and elbow surgeons at University Orthopedics. I do surgery. And I predominantly do surgery just on the shoulder and elbow, and most of that is on the shoulder, and a fair amount of that is shoulder replacements. It's something that not a lot of people know a whole lot about. Seems to be a lot of concern, questions, confusion sometimes with patients that I see. So hopefully I can provide a little bit of background information, and information about the procedure, what to expect if you're somebody that it may apply to clear that up and get everybody a little more educated on the topic. So we're going to go into the talk here. So we're going to be talking about diagnosis and treatment of common types of shoulder pain. Mainly, we're going to be talking about shoulder arthritis. So I think it's important we just review a little bit of the anatomy, or what the shoulder looks like, what the bones look like. So we talk about the shoulder and we think about it as being one joint, but it's actually four different joints. There's what we call the glenohumeral joint, which is the ball and socket joint. That we see on the screen. There's the acromioclavicular joint, which is kind of this little knuckle type joint on the top of the shoulder. The sternoclavicular joint, which is the medial or the end of the collarbone close to the center of the body. And then there's also an articulation, or kind of like a joint where the shoulder blade rubs on the back of the chest, and where the shoulder blade moves around the chest. Most of the motion in the shoulder occurs at what we call the glenohumeral joint, which is the ball and socket joint. And it's kind of shaped like a golf ball on a tee. It allows for a lot of motion, but it does require a lot of soft tissues to provide stability, mainly the rotator cuff. And so the rotator cuff is four muscles and their tendons. And so what tendons do is they attach muscle to bone. So it goes muscle, which is pretty big, comes down to a small tendon, and that attaches to bone. The four muscles of the rotator cuff are the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. It's really not important that you know the names of them, but just know that they're muscles that surround the ball and help hold that ball in the socket, so that the shoulder can function the way that it's supposed to, and provide a stable fulcrum so that there's motion of the ball within that socket. So moving on to arthritis. So arthritis is something that very commonly affects patients in their hips, in their knees, and joints in their hand. People are not often as aware or familiar with arthritis in the shoulder. The main reason is because arthritis is not quite as common as some of the other conditions around the shoulder, such as rotator cuff tears. As we can see here on the screen, this ball and socket, which does not have arthritis, the socket's really pretty shallow. It's like a golf ball on a tee, like I said. And so you need all those soft tissues to hold the ball in the socket, and that is what creates stability of the joint. But also, because the soft tissues are so important, it's a little more common to get soft tissue injuries around the shoulder, like rotator cuff tears, than it is to get arthritis. But arthritis still exists. It's still quite common. It's still something that we treat. The other thing is that we don't walk on our hands, or most of us don't walk on our hands. And so unlike the hip and knee, we're not bearing weight on our shoulders. And so this is what happens during arthritis. We get all these bone spurs and things like that, which we can see on that x-ray. And so we'll talk a little bit about the symptoms, the type of arthritis, and then treatments. So people generally have a pain deep in the shoulder. And like a lot of things that affect the shoulder, it bothers them at nighttime. It gives you a lot of trouble sleeping. It can wake people up from sleep. Also get stiffness in the shoulder with arthritis, lose motion. People often notice that it's difficult to reach their arm back behind them and put on a coat, or reach into the backseat of a car. Also grinding sensation when moving the shoulder, and that all ends up creating decreased function of the shoulder. So there's two types of shoulder arthritis that we kind of break things into. Shoulder arthritis with an intact rotator cuff, where the rotator cuff is functioning well, those tendons are nice and intact around the socket. And then shoulder arthritis with a deficient rotator cuff, where the rotator cuff's not attached to the ball. And we'll talk about that a little bit as well. So for the cuff intact arthritis or osteoarthritis, we generally start treating this without any surgery. The first lines of treatment often are steroid injections, maybe some physical therapy. The steroid injections we can do up to every 3 months. Patients with diabetes should expect to have elevated blood sugars for about 5 to 7 days after a steroid injection as a result of how the steroid interacts with the body. There's something in the lower extremity that I get asked about a lot that is used, which is called viscosupplementation, where this very, very kind of slippery type of goo, for lack of a better term, is injected into the knees to help lubricate the joint. Unfortunately, it's not approved in the shoulder, and it's something that we don't use in the shoulder, but that is something that I get asked about. So what about when these non-operative treatments stop working? That's when we go to a shoulder replacement. And what that means is we resurface or replace the ball with a metal ball, and on the socket, we put a plastic socket. We get excellent results with this. There's a long lifespan. We're able to restore function and activity levels. There's a low rate of complications. The average age of patients for this is about 65. It isn't changing too much, although we are doing patients who are younger if they are a good candidate for this, or if they have some sort of condition that's caused them to have shoulder arthritis at a younger age. And we're also doing it in older patients as we see patients live longer, be more active, and doing it in patients, into their 80s, even into their 90s in select cases. So what do we do during this procedure? We make an incision on the front of the shoulder. We have to detach one of the rotator cuff muscles in the shoulder to be able to get into the ball and socket joint. So we discussed before that the rotator cuff surrounds that ball. So we have to get in there. We have to detach one of those so we can get in there and do our work. And that's called the subscapularis. And that plays an important role in the rehabilitation and the recovery after shoulder replacement. And we repair that at the end, and we need it to heal down to get good function. We also remove scar tissue. We release any adhesions or anything that's blocking motion to get you full motion at the end of the surgery. And then the rehabilitation is really important to keep that motion. So these are just some graphics and some drawings here showing how we reattach that tendon back to the bone, which we do using stitches. But then we need the bone and the tendon to heal together to form that solid, strong bond. Originally, shoulder replacements were done using a stem, like we see here, where there's a portion that actually goes down inside the bone. We usually use a head that's made out of cobalt chrome or metal, and then we reshape and resurface the glenoid socket and cement in a plastic portion. And so there's the part that's on the ball side, there's the part that's on the socket side. You can't really see that very well on an x-ray because it doesn't show up on an x-ray because it's plastic, but I'll show you some pictures in a minute. We can also do what's called a stemless component. So this is some newer technology that we're using where we don't have to have a long stem that goes down the center of the bone. We just use right here, like we see, it's a very short stemless component. So if you need to have this redone at some point in the future, it's a lot easier to take out, and it gives us better options if you do need to have a revision in the future. And this is important, especially for our younger patients that may live longer than the component lasts. On the socket side, this is what we use. On the glenoid side, we use this plastic socket. Polyethylene is the type of plastic that we use that gets cemented into place. So now you have a metal ball that's contacting a plastic socket, as opposed to the bones that you had before where it was bones on bones rubbing and causing all that pain. So recovery after the surgery, typically patients go home either the same day or the day after surgery. We are doing more and more outpatient surgery for this, both at our facility here at Kettle Point, where we do outpatient total shoulder replacements and other total joint replacements, and also at the hospitals, depending on which location is right for you. We generally begin physical therapy right away to do some stretching using the other arm to move it around, but not moving it around on its own. It's gentle at first, and we use that sling for 6 weeks. So for 6 weeks, you're going to be in a sling, And that's to get that front tendon that we had to release to heal back down to the bone. After the 6 weeks, you can start using the arm for lighter activity. You can use it in the sling for some gentle activities right away, such as eating, holding a piece of paper, really anything you can do in the sling. Most patients use pain medication for 1 to 2 weeks, and there's no driving generally for 6 weeks, or at least not using the arm that you had the shoulder replacement on. Most of my patients, sometime between the 6 and 12 week point, tell me that their shoulder feels better now than it did before surgery. There's still recovery that happens up to 6 months, and even to a year, you get some improvements. But usually somewhere between that 6 to 12 week time point, they say they feel better than before surgery, and they just got the achiness and the pain from surgery, but that arthritis pain that they had before has gone away. Golf, generally they can start chipping and putting at 6 weeks, long game at 12 weeks, and then playing 18 holes at 3 to 4 months. So functional expectations after a total shoulder replacement, patients should expect basically to get full range of motion, excellent pain relief, should be able to perform their daily activities and get back to activities such as golf, tennis, swimming. We do put some permanent restrictions on patients, mainly on things that are going to be very high impact and repetitive, such as jackhammering, chopping wood regularly, boxing, martial arts, or heavy Olympic style weightlifting. But most patients can get back to all activity, and that's really what they should expect after a total shoulder replacement. The lifespan of these implants, it's a little difficult to know exactly what the lifespan is of the implants that we're putting in now, because the ones that we're putting in now we think are better technology than the ones that we put in 30 years ago, but it's going to take us another 30 years to know exactly how the ones that we're doing now are lasting. But generally about 15 to 20 years, the vast majority of them will still be in place and doing well. The most common mode of failure of these replacements is on the socket side. So that plastic socket that was cemented into place, that generally loosens. That's usually what the issue is down the line if this implant were to fail. So moving on to the second type of arthritis, which is this cuff deficient arthritis, sometimes called cuff arthropathy or cuff tear arthropathy. And this is usually something that happens secondary to having very large tears of the rotator cuff for a long time. And what happens is when you have these large, long-standing tears of the rotator cuff, it leads to decreased ability of that rotator cuff to hold the ball in the socket. And what we'll see here, we see an animation here that shows some tearing of the rotator cuff, and we can see the tendons that are torn around there. And they're in charge of holding the ball in the socket. When they can't hold the ball in the socket anymore, the ball rides up. We call that superior migration, where instead of the ball being lined right up with the center of the socket, it now moves up and starts grinding on the underside of that bone called the acromion, and it's not lined up with the socket anymore. And so that causes pain, dysfunction, and weakness. And because the incompetent rotator cuff is no longer holding the ball in the socket, the humeral head can escape out of the socket and start rubbing on other bones. And this is not uncommon as patients get older. The pain is similar to osteoarthritis, but one thing that's very different is, unlike an osteoarthritis, these patients are weak as opposed to being stiff. They generally have full motion if I move their arm around, but they're not able to move their arm around on their own, which is different than a patient with osteoarthritis, who it doesn't matter if I'm moving their shoulder, they're moving their shoulder, it's just stuck, it's stiff. And so on these x-rays, we see this high riding humeral head. That's what we call it, where the ball is now touching the bone above it, as opposed to being down in the socket down here. And we can see that right there. Those two bones shouldn't be touching each other. Some terms that are used with this, something called the acromiohumeral distance. That's the distance between the acromion bone and the humerus. Normally it should be about 1/2 inch or a 1/3 of an inch, but it gets down to 0 because those two bones are rubbing on each other. And then we use terms like acetabularization of the acromion, which an acetabulum is actually part of the hip. It's the name of the socket of the hip. And so the shoulder actually starts to look like a hip joint instead of having a golf ball on a tee, you've got more of like a hip joint, like a deep socket, but it's not really designed for that, and that causes pain and problems in the shoulder. And so in this cuff deficient arthritis, why don't we just use a normal total shoulder when the patient gets to a point where they need a replacement? And that's generally when injections are not providing good relief, when there's pain that's limiting activities of daily living or activities that are very important to the patient, and the symptoms of the shoulder are just not tolerable. That's when we start talking about shoulder replacement. The problem is if we just put in a resurfacing of the socket, that plastic glenoid piece, and we resurface the ball with a metal ball, it doesn't restore the fulcrum and it doesn't take care of those big rotator cuff tears, and they fail early. So the ball, instead of staying in the middle of that socket portion, actually rubs on the top, and you get what's called a rocking horse phenomenon, and it rocks that piece loose. So within a year or two, the socket will loosen. And not only that, the patient still won't be able to raise their arm because you haven't done any to counteract the rotator cuff being torn to a point where it's not fixable. So along comes something called the reverse shoulder replacement, which a lot of patients have heard of, but they don't quite understand what it is. And basically, it's a reverse, or sometimes called an inverse, where instead of having the ball in the socket like this, we switch them. We put the ball where the socket was and the socket where the ball was. It was FDA approved in the United States in 2003, and we've been using it quite a bit since then. And it's gotten to a point now where we put in about the same amount of reverse shoulder replacements than we do the regular total shoulders. It has increased constraint, and it changes the distance between the humerus and that acromion bone, and it changes the center of rotation of the shoulder. You don't really need to know any of that to have one of these done, but we know it, and we know how to use it, and we know that in a patient that's unable to raise their arm because they have these big, long-standing rotator cuff tears that can't be fixed, when we do this procedure, then they can, and now instead of bone on bone, we have metal contacting plastic. And so these are just pictures of a couple of patients. There's a little bit different functional expectations with the reverse shoulder replacement, although this is becoming less and less. We're getting better and better at this procedure. As the years go on, as we use it more in the United States and we get more long-term data, the design of the implants are getting better, and our techniques are getting better too. In the beginning, it was reserved for patients who are 75 or older, without very high expectations for the shoulder, and that's not the case. We're using it in younger patients, and there's some other indications that we're using it for as well, with very good results. It's very good at providing pain relief, and it's very good at being able to allow a patient to raise their arm when they couldn't raise it before because they had those big rotator cuff tears. Recovery is very similar to the total shoulder, the same time in the sling. All the timelines are pretty much the same, except we don't do much therapy in the beginning. There's a little bit less therapy with the reverse. And the goal of the surgery is pain relief and functional range of motion. But this can be a very good option. And like I said, the indications are expanding a little bit. So there are patients that maybe would have gotten a total shoulder 10 years ago that now we think a reverse shoulder may actually be a better option for them. What about younger patients? So indications are expanding, and there are certain conditions that can affect younger patients, whether it be a bad fracture or something else that's left them with arthritis in the shoulder. We have options for patients 30, 40, even rarely in their 20s if they have, extenuating circumstances. And that's where some of these newer technologies, where we don't have to take away as much bone and they're easier to redo down the line if need be, allows us to do it in younger patients, like I said, 20, 30, 40 years old if they're the right patient. So some take-home points for shoulder arthritis. The first-line treatments, anti-inflammatories, modifying lifestyle. Then we go to those injections of cortisone or corticosteroid, which we can do up to every 3 months. And then shoulder replacement, which is the gold standard surgical treatment for this. We get predictably good results in recovery. It's very durable. There's many options of types of shoulder replacements. We've went over a few of them, and many different conditions that we see. Like I said, the surgery generally requires one night stay in the hospital, although we are doing more and more of them as outpatient procedures. You're in a sling for 4 to 6 weeks after surgery, generally pain medications for the first 1 to 2 weeks. The last thing I'll say is that when picking a surgeon to do a shoulder replacement, one of the most important things we know is to find a surgeon that has a high volume of shoulder replacements, somebody that does a lot of them. At University Orthopedics, we have specialists like myself who basically only see shoulder and elbow problems and do a very large amount of shoulder replacements every year. And there are some studies to show that overall outcomes are likely better in higher volume surgeons than somebody who may dabble or do 1, 2, or 3 of these a year. So that's something to think about when selecting a surgeon if this is a procedure that would be right for you. I'll just put on the screen there my contact information, my office phone number 401-457-2157 to make an appointment if you're having shoulder pain or shoulder condition or would like to know more about these topics that we covered. And we'll go ahead and take some questions now. A couple of questions are coming in here. A question, is the shoulder going to feel different if you have a reverse compared to a normal total shoulder, or different than just your normal shoulder? Well, I can say it's going to feel different than it did before surgery. It's going to feel better because you're going to be replacing that arthritic shoulder that has bad rotator cuff with a nice new replacement where you get the metal and the plastic rubbing on each other. So that's one thing. It's going to feel better than it did before the surgery. Will the patient know? Will you know if I did a total or a reverse on you and I didn't tell you? Probably not. Somebody who's familiar with it may be able to look at the shoulder. Sometimes it can look just a little bit different, just as you could see on that slide where there's a little bit more space there. But for the most part, no, you really won't know. And that's really one of the great things about the reverse shoulder replacement is that it's not some very strange feeling. It doesn't feel like your arm's backwards or upside down or anything. Patients really can't tell, and the results are really quite good. And so that is not something to be worried about. Another question that's coming through would be, what are the limitations after surgery? You're going to get back to doing the things that you want to do. And I would say the patients that I do shoulder replacements on, not only are they not limited after surgery, they're actually the opposite. Because they've been living with this pain for so long, if they're a good candidate, there's somebody who's got, arthritis on their x-rays, they're waking up at nighttime with pain, they're not doing the things that they want to do because the shoulder hurts. Those patients are able to go back and live their lives after the surgery. And so not only are they not limited, they are expanded in what they can do. They can go back to playing golf and playing tennis and, playing basketball with their grandkids or kids, skiing and things like that. Really, the only things that we don't want patients to do after a shoulder replacement, again, because they are mechanical parts, is anything that's going to give repetitive impact on those pieces that could cause them to loosen or wear out. So like I said, jackhammering, chopping wood, punching a heavy bag often, things that are really going to give that repetitive impact. But anything else really can go back to almost any other activity. And patients, but a lot of them, golf is something that's important in this patient population. They get back to golf, they get back to tennis, and a whole slew of other activities that anything really that you could imagine. And another question, how do I know if I'm a candidate for shoulder replacement surgery? The short answer is you really won't know until you have a consultation with the doctor who does it. Because I've had a lot of patients that have come in, they said, I've been dealing with this for 10 years. Somebody, a long time ago told me there was nothing that can be done. So I just thought there was nothing can be done. well, that's not the truth. Things have moved on in overall medicine, and we've advanced, and there's been innovations, and we're able to provide a treatment for them that's able to greatly and drastically improve their life. Um, but generally, somebody who would be a candidate for a shoulder replacement, again, is going to be somebody who's medically healthy, who's able to undergo a surgery. It's not to say that we don't do this surgery on patients who have other medical problems with their hearts or their lungs or on blood thinners. It just takes a little more planning ahead of time for us to work with their medical doctors or their oncologist or their hematologist or their pulmonologist or cardiologist or whoever it may be, for us to make sure that it's safe. And then it would be somebody who has an arthritic condition of the shoulder that's limiting their life in a way that they are unwilling to tolerate. And that's a lot of patients. And shoulder replacement surgery is the fastest growing type of is the fastest type of replacement surgery of any joint in the United States. It's growing much faster than hip and knee replacements because people are becoming more aware of it. More patients are having it and realizing how well they're doing, and telling others about it. And our technology and our techniques have gotten better. So it's not the same shoulder replacement we did in the 1970s. Things have gotten a lot better with great results. Before, if you had this surgery 40 or 50 years ago, you may be in the hospital for a week. Now we're doing it as outpatients. So, things have really changed. So I'd like to thank everybody for watching and tuning in. Hopefully you learned a little bit about shoulder arthritis and shoulder replacements. And hopefully if there's some patients out there who are having shoulder pain, who think that nothing can be done, they, reach out, come see us. Phone number is 401-457-2157. And hopefully we have some treatments that can benefit you and help get your life back on track and getting you doing the things that you want to do. Any other questions, feel free to call my office or come in and visit me, and we can discuss any problems with your shoulder. Thank you very much.